Hello, I'm Dr. Roger Klein. I'm an orthopedic surgeon in Santa Rosa, California, and I would like to illustrate the ultralight postoperative fiberglass casting technique we use on upper extremity. This casting technique would be applicable for a child having a supracondylar fracture of the humerus, which is pinned. It can be beneficial for somebody with open reduction internal fixation of a bicondylar supracondylar fracture used with plates and possible olecranon osteotomy. It can be used for olecranon fractures or even for forearm fractures. This particular cast will go from the wrist up to the shoulder, and it'll be split in the front so that it's not too tight, and then overwrapped with an ace wrap. So we're going to begin. This is during surgery typically, and the patient will have padding under here. I'll have an assistant to help me. This is with an 8x10 ABD and another smaller ABD to the front. These are held in place with a Curlex roll. And we try to apply them as smoothly as possible so there are no creases or bends. Often these surgeries, patients will be in a supine position, and so the arm is elevated over the body. Since my assistant can hold that, we'll have her hold it. Do the forearm part with continuation of ABDs. The ABDs are accommodating to a swelling. They're sterile, they're comfortable, they're absorbent. And we have one pass where we've actually gone below the ABD, and we've torn one of the ABDs longitudinally. We want to make it as smooth as we can. Wrapping around the elbow, and then another down here on the forearm. I've used the Curlex instead of a web roll because it's continuous and won't fall off as we wrap. Once it's uniform, we check for any pressure points. Make sure it's continuous and uniform. Possibly we can put one more back on, posterior to the elbow where more protection padding may be needed, and then we'll overwrap with Curlex. No taping is needed for this because we're going on to fiberglass as soon as we finish. We put on a very thin layer of fiberglass. We already have internal fixation hardware or key wires in place, so we will adjust the position as we set the fiberglass. One layer of web roll is sufficient. We'll make sure it's all covered. Looks good. We want to make sure we don't fiberglass the patient to the operative table. So we're going to use a very light roll, single roll. And as soon as it's hardened, we'll trim it and bite it out. So in this particular case, we're using one roll of 4-inch fiberglass. This technique would replace a long arm posterior splint and would give better swelling control. We're down in the operating room. We're going to bend your elbow, bend it up. Let's flex. It turns out that 2 layers of fiberglass is very strong, and in most areas will prevent it from buckling or breaking. But if there are any areas, as you see here, where there's no coverage, it's weak and it will break through that area. Also, because of the ABDs that are on there, it'll be smooth even if we have any creases or folds in the fiberglass. Now that we have it fiberglass on, we'll check to make sure we have all areas covered. Bend the elbow a little bit more to a flexed position. This crease is going to be removed, so it won't be a problem for the cast. This will take a set in about 2 minutes, and then we'll cast it and we'll split it. How's it feel in there?
Great. Really comfortable.
So at this point we have a long arm cast. It's a very well padded inside, more padding than you would typically have in your normal cast. But this will accommodate swelling postoperatively much better than your typical coaptation fiberglass splint. The splint could be used as a forearm splint only, or it can go out over the hand, but I find it's better if we can get the wrist and hand to move. So we'll usually leave it free and just protect the elbow for elbow fractures or proximal fractures. Okay, once you hold it right here, that's good, just raise your hand. So now we're going to, it's going to be hard in just a minute. We're going to trace out our line. If you're doing this in surgery, you don't really need to trace it, but if you have an assistant that's going to turn this off for you, you can go ahead and trace it at this point, and they can get it from here. We're going to take out a small section in the front that gives us some support and rigidity on the upper brachium and gives us flexibility at the elbow without making it so thin that it breaks, and then a small section down at the wrist. So then when it comes later in the office, we can take this off without actually having to use a fiberglass saw. So if it's a child, there's no noise to frighten this child. So at this point we're going to bivalve and take off fiberglass in that small section. Does it feel hard?
Yeah.
It needs a little bit more time. Okay, pretty good. Once again, the fiberglass is split while it's patient's asleep. And on the upper extremity, it doesn't appear to be so necessary to split this, but it can be split if you think that compartment syndrome may be an issue. Because the fiberglass separates from the web roll, it's actually very flexible at this point, and you can separate it here. You can separate it in the forearm. It's very lightweight. Sometimes if you feel like you need more, you could use a couple 3-inch fiberglass rolls instead of one 4-inch. Once this is in place, it's circularized and snugged up by putting the fiberglass, by putting the 4-inch ace wrap around it. Once again, it's not necessary to get complete coverage of all the fiberglass, but we have plenty of ace wrap to do so. And the patient would be put into we have arm elevated onto pillows at this point rather than arm sling where it may be too low. We use ace wraps that have Velcro fasteners so we don't have to worry about clips catching the patient's bedclothes. The ace wrap then is overwrapped with a transport tape to keep it securely in place. And that's the ultralight fiberglass postoperative dressing for the upper extremity, best used for olecranon fractures, supracondylar percutaneous pin fractures, or plated supracondylar fractures. How does it feel?
Right?
Does it feel tight?
No.
Does it feel loose?
Feels supportive.
Can you move your elbow?
Wrist?
Can you move your wrist? How about your elbow?
Only a tiny bit.
Pretty secure, a little bit. Now it's 12 days later, and we have successful early healing. Patient's in minimal pain, and it's time to do a dressing change and wound check, possible staple and suture removal. So we're going to take off the ultralight upper extremity fiberglass split. I like to do this without the cast saw so that patients, young patients particularly, that might be fearful of the cast saw won't be alarmed, won't be frightened. And with sharp dressing scissors, these are easily removed. This can also be converted for use later for a follow-up splint, easily used simply by releasing through the web roll and leaving the Kerlix still in place. In this case, I'm releasing the Kerlix, so it'll be easier to take it off, and we'll remove the Kerlix so we have a postoperative splint for later use as well. So it's easy at this point to release it and take it off. We have extra padding in here, and we can go ahead and do dressing care. Washing the arm, removing the staples, and necessary putting back another splint so we can start early range of motion. This completes the demonstration on the ultralight fiberglass splint for the upper extremity. Thank you.